I'm gonna stop sharing so I can see. Keep going on. Hi, everyone. We're gonna get started in a couple of minutes. Just gonna wait for folks to get on. For those of you just joining, we're just gonna give it a couple minutes to let everyone get on and then we'll get started. I think it might be okay to start, Javi.
Yeah, we can go ahead and get started. Hi, everybody. Thank you for joining us. My name's Javier Sanchez. I'll be standing in for Carolyn this webinar. I just have a couple of quick housekeeping announcements. At the conclusion of this webinar, we ask that you please fill out the evaluation form that'll automatically generate. You'll be redirected to it, rather. So we can get your feedback and so we can keep doing webinars like this. A second thing, a quick note about CEUs. We're still kind of fine-tuning our CEU process. So this time we will have, Carolyn will reach out to you with a link that will help you, and we'll just take a couple of, we'll have you fill out your name and a couple of other things. And that will help you, and that will generate a CEU for you. So be on the lookout for an email from Carolyn next week. And that's it for me. Thanks.
Great. Thank you, Javi. I'm gonna share my screen and then let you know what we're doing here. Okay, is that, can you guys see that okay?
Yes.
Okay, great. So, some of you know me, others people probably don't. My name is Sandy Magana. I'm a professor in the School of Social Work and also the director of the Texas Center for Disability Studies. And we're going to be talking about um, our intervention called POVER, which stands for power, and it's about health promotion for Latino families of children with autism and other developmental disabilities. And some of you may have attended the webinar that Amy did back in December, where we actually presented the pilot findings from this study. And so I'll kind of go over, sort of the iterations that we've done, but this is new results that we're actually presenting right now. And Amy, do you want to introduce yourself?
Thank you, Dr. Magana. My name is Amy Yu, and I'm a postdoctoral fellow at UT Social Work and TCDS. And yes, I presented at, it was 2023, I believe, in December. So it was quite a while ago. So at that time, we actually did not share a whole lot about the pilot study results yet. So since it was still in progress, but today we will be sharing both.
Okay, great. Thank you. Yeah, so just to get started, so these are the learning objectives that of the webinar itself, right? And I'm trying to move things out of the way so I can see what this says. Yeah, so we want you to be able to explain the rationale for cultural tailoring and health interventions. We want you to be able to identify the core components of the intervention we developed and be able to apply some of the lessons learned and be able to talk about this policy implications. Yeah, so I'm going to talk a little bit about why it's important to culturally tailor interventions, and I'm sure many of you already know that most evidence-based interventions, whether they're about autism or other for other families and children, um, they're not tested with culturally diverse populations uh, generally. And diverse groups have unique needs and often fall through the cracks of the healthcare system. And if the intervention is not specifically tailored for them, that increases the likelihood their needs are not gonna get met. And I know it's important to reduce disparities and build on community strengths, also to optimize community engagement through using culturally tailored interventions. And I just wanted to share with you for an example of how, you know, underrepresented people of color and also low-income people are in autism intervention research. So there was a review published in 2022. They were reviewing autism intervention studies specifically, and they went through about 1,013 articles, and out of those, only 25% reported any data on race and ethnicity. So 75% of them did not report, what racial ethnic background the participants belonged to. And there was a slight increase in reporting over time. So they looked at a period of maybe about 10 years, and they found that in the later years, there was an increase in reporting, but so it's getting a little better. The studies, the 25% that did report, about 65% of the participants were white, 9.4% were Latino, 7% Black, and 6.5% were Asian. So there's some diversity in that 25%, but it doesn't really match the census numbers. And so we have to think about why people are underrepresented. People of color are underrepresented in these intervention studies. So there's a lot of different things to consider, like I have to move this. As a mistrust of healthcare providers, right? And that could be for different reasons for different groups, right? And they might be conducted in unfamiliar settings, or they are far away from their communities. They may not be able to take time off work, um, and can't afford to do that. And they may have multiple caregiving responsibilities. They may not have fast and reliable internet if that's required. Often non-English speakers are excluded from those studies. And another thing is that many people from diverse backgrounds are diagnosed later. So when you're doing your study, there may be a group of people out there that really do have autism that were never diagnosed, so they're not going to make it into your study. Okay, so thinking about disparities in autism services, there has been research on that. Um, there are significant disparities among children who are from racially and ethnically minoritized backgrounds, those with low resource backgrounds, families in rural areas, um, and very few parent-mediated interventions have been created or adapted for these populations. There's language barriers, financial burden, discrimination, and social isolation. Those add to the risk of adverse health outcomes for many of these families. There is some research, I think culturally adapted interventions is growing in the autism world, in autism research, but there's a lot more robust research in mental health in general for children or adults. And they have done a lot of cultural adaptations of interventions in that field. And so we can draw from that to see that there were a couple of meta-analysis done where they looked at multiple studies, and they found that have actually done cultural adaptation, and they found some moderate to large effects for culturally adapting interventions, so good outcomes in those cases. And the studies that were conducted in the client's native language were twice as effective as those in English. And think about this, I mean, there are a lot of people who have maybe aren't super proficient in English. They maybe can speak a little English, but aren't proficient. Oftentimes they're included in studies, but not in their native language. So thinking from that perspective. And then interventions tailored for specific groups were 4 times more effective than those provided to all groups and kind of generalized. This is just kind of showing how cultural adaptation really takes an iterative process. And it really starts with creating alliances with stakeholders, then deciding what the intervention is going to be based on that feedback, right? And so it could be an existing intervention that you're going to adapt, or it could be something you're going to create because there's nothing else that exists that will meet those needs. So then you either make the adaptations or create the intervention, and then it's important to do a pilot study. So we were talking about the pilot, and we'll give you some of the results from our pilot study. And then you have to evaluate the results of the pilot and make changes again to the intervention based on that feedback. And then you update it and run the intervention again, and preferably doing a randomized controlled trial so that you could see if the intervention is effective. So that's sort of the process that we've engaged in with this study. And just to go over, like, these are some of the best practices for adapting or developing culturally tailored intervention. So, as we mentioned before, involving stakeholders, super important. Consider using peer-based recruitment and delivery methods. That's something that we've done a lot of, is, for example, with the caregivers, if we're providing intervention to them, we want the people delivering it to be also caregivers and also from their community, so their peers. And that's real powerful in many different fields. I think, mental health and other fields are using peer-based kind of interventions as well. And then, of course, you have to create or adapt materials and translate them for the group, ensure that the content is relevant for that group and salient for them, ensure accessibility and reduce effort and barriers for folks. And then I don't know if we're presenting this framework right now, but we've used a number of frameworks. I think we might be talking about the ecological validity framework. We used another framework I'm not sure we're going to talk about, but um, this is just an overview slide. I'm not going to go through this whole thing, but the Poder study, which was funded by NIDLR, started over 6 years ago, and we just finished it. And so we had these kind of 3 phases that we went through. First, we examined what the outcomes were for children with IDD, and then we did a lot of interviews with families and children. And then thirdly, it was the intervention process that we just described. And I think I'm going to turn it over to Amy now.
Thank you, Dr. Magana. And yes, so we started PODER is an acronym for a very long acronym, promoting obesity prevention among Latinx children with developmental disabilities and families through engaged research. And then we call our intervention Poder Familiar, which means power family in Spanish. The intervention has 2 goals. First is to promote the health and well-being of caregivers as well as children with IDD and the whole family. And second is to maintain a healthy weight in next children with IDD and caregivers. And how we come up with the final product, we actually went through many, many stages, but the initial manual, we took 2 curriculums that have been shown to be effective with Latinx families of children with disabilities and tailored the content. We merged those 2 manuals and then tailored the content to the participants for poder familiar. And then we also tweaked a lot of different elements, which I will share later, to not only to the tailoring it to our participants culturally, and also the content-wise, our topics, we tailor it more to the health and well-being of children and their caregivers. Next slide, please. And these are our 10 sessions that was delivered by Pomotora. I will briefly describe about the Pomotora model later in the next slide, but it is basically a peer mentor model. And we have 10 sessions. First session talks about the introduction of what the whole program is about. Second session is a broad overview of what does it mean to care for yourself, learning about what is stress, depression, just the self-care strategies. And session 3 is stress management, is really taking a deeper dive from session 2 into understanding stress and how does that affect us biologically and psychologically, and more strategies on how to manage that when encountering a stressful situation. Session 4 talks about balanced diet. Session 5, physical activity. Session 6, talking a lot about more of the chronic disease and eating habits. And session 7, more physical activity, but it's more for the family. And then session 8 on grocery shopping, meal prep, and understanding nutrition labels. Session 9 on social support and well-being, and session 10 on healthy decision-making and managing the environment. So all of these sessions also included a 3-group session that was delivered by staff, and they were all delivered virtually. And so we utilized one of the critical elements of our interventions that we utilized the Pomotora Salute model, which is utilizing peer mentors, and they are in our case, they are mothers of children with IDD. And because of that, they had that shared identity or just shared experience with the participants. They're able to share a lot of their own experience, a lot of their strategies that they've used, that they worked or not worked. And that is fitting for also not only to the participants' environment, but also tailoring to the culture piece. They're all both all bilingual, and that they understand the host community. Next slide, please. And in our Poder Familiar, we utilized our community advisory board at many points of our intervention. Prior to the launching of the intervention, we've consulted with our community advisory board, which consisted of community partners, local staff, professionals in social services, the research staff, and the next parents of children with autism and other GD, and other autism experts. And in this advisory board, we talked a lot about our going through the curriculum and to see if there's anything that needed to be edited before we launched our program. Next, please. And here are some of the adaptations. We made a lot of adaptations tailoring to our to the target community. And first and foremost is the linguistic preferences and health literacy level. So all the materials were made available both in English and Spanish, depending on their preference. And was also made at 5th grade level of plain language and metaphors. We use a lot of metaphors and brief short stories that have shown to work in the past with culturally, as well with the community, and that parents can relate to. Another adaptation that we did was the behavioral preferences and ways of doing. We've incorporated a lot of visuals, inclusions of and discussions of different ways of preparation of meals, at different discussion points to make this more interactive. We've also adapted the values and the ways of thinking, particularly in terms of incorporating values such as familism, and a lot of the sayings and the myth that was more culturally relevant, and discussion of that, particularly on different health myths and different diet myths surrounding disabilities. We've also incorporated the goal setting and behavioral management strategies. We've used a traffic light analogy, which has shown to be effective in previous studies, which is a very simple tool to help participants and the promoters to set goals and to see which goals are going well, or which ones are needed work, and which ones are still in the progress. And we talked a lot of we incorporated accessibility, which is unique in our intervention as well. We incorporate the part where we try to help our parents understand and overcome issues that may hinder physical activity or diet or nutrition. And so we included a lot of discussion points on that for the Pomotora to help the participants as they brainstorm what are some of the strategies to make this more accessible. And we've also adapted social and cultural and the spiritual physical environment. Talked a lot about the different types of symbols, artifacts, or and the music that could help the health and well-being of family caregivers, and how to navigate the environment where there's where to incorporate exercise, or to incorporate a health to eat a healthier lifestyle. We also developed a toolkit of resources that's relevant to that local community, and because this study was conducted at 2 sites. It was here in Texas and another in Illinois. For the pilot, it was in Texas, was focused in Austin, and in Illinois for the pilot was in Chicago, and then we opened up statewide for the RCT. Our toolkit was basically more tailored to that, so we developed separate toolkits for both sites. And lastly, we've for our format of delivery, we utilized formatoras, as we've mentioned, and it was a one-on-one session, so it was very easy to reschedule and much created a much stronger social connection because of that. And as for the group sessions, it was helpful for social learning and learning from other parents. And next slide, please.
Sorry, I'm just yeah.
And we trained our promotoras at various at the beginning and in the midpoint of the intervention. They're required to attend, and they're required to review all the curriculums in advance. And so it was across both sites. It was 4 modules, 2 in the beginning and 2 in the middle as a checkpoint. And was conducted by experienced facilitators and also experienced promotoras who were able to facilitate role playing and discussion of different points. And we talked about building rapport. We talk about cultural humility and setting boundaries, problem solving and involving other family members, and technology use, and other documentations. And throughout the intervention, we provided ongoing support. So our project coordinators met with the promotoras bi-weekly to troubleshoot anything that came up with during the sessions that needed to extra resources or some talking points to the parents. We were able to provide that ongoing support throughout. And like I said, mentioned, we provided a toolkit, so as an extra resource for the caregivers. Next slide, please. And here are the results. Next slide, please. Yes. So for the pilot study, 30 families were enrolled, and 24 of the 30 children had autism. And we conducted a feasibility and acceptability evaluation. And for the feasibility piece, 13 out of 15 Texas participants completed all 10 sessions. And also, similarly, in Illinois participants, 13 out of 15 participated in all 10 sessions. So we have high attendance rate, and in the in-person group session. So in our pilot study, because it was local, it was we in Texas, it was in Austin, and then in Illinois was in Chicago. We had in-person two in-person group sessions, and then the third one became remote. We had a good turnout, but it was difficult to coordinate, and uh, uh, and that's why we moved the third session to the remote session, because it was easier to coordinate and less. But then it turned out to be there's less participation. And a quick note here that for our CT, we because of this, we've decided that all 3 group sessions was conducted remotely. And then we also conducted fidelity checks to make sure that our intervention is um, aligning with our protocol, and it showed 94% of fidelity. And next slide, please. So here are just some of the evaluations that we've done. Most participants agreed that the content covered was relevant, organized, and easy to follow, and focused on their needs. They were feasible, and the time allotted was adequate. And participants agreed that their promoters were well prepared and sharing their personal experience, and encouraging and supportive. And they talked a lot, they gave a lot of feedback, and in the areas of improvement, in content and organization, in the slides, in the toolkit, in the modality, in the ways that they could receive social support or support from our staff, compliments and more compliments, and then and the logistic part of it. So the using Zoom, and there's the technology issues. And they talked about other topics of interest. Next slide, please. And from our pilot study, we found that caregivers, we found that there was a significance in their improvement of mental health, and in health efficacy, and in the decrease in unhealthy food intake. As for children, we also found significance in increase of physical activity. There's decrease in total added sugars intake, and there's better physical and mental health overall. And I'm going to turn this over to Sandy, and she's going to talk about what we've tailored for our RCT.
Yeah, great. Thank you, Amy. That was really good. And so after doing the pilot study, we made some changes that included streamlining the sessions a little bit more. So we adjusted the structure to allow for more discussion and reflection. And then we enhanced the videos. They really like to see more visuals in the materials, so we did that. And then we added some more interactive elements, including more discussion points, different activities, and health-related video links that we could share, that the promotora could share with the participant. And then we tried to ensure consistency and cultural relevance. By revising terminology for broader cultural appropriateness with the Latino population. And then we improved our own processes of, tracking goals, because part of the intervention is setting goals with participants. And we wanted to make sure we're tracking, like, are they actually completing those goals, or, how are they thinking about them in the end? Yeah. So then, in terms of the methodology of the randomized control trial, we had 55 Latina caregivers in Texas and Illinois. 26 were in the intervention group, and 29 were in the control group. And out of the 26 kids in the intervention group, 24 had autism. And in fact, of intervention and control, 80% of the kids were autistic in the study. And we weren't specifically recruiting. I mean, we were recruiting for people with any intellectual or developmental disability, but maybe they tended to be ones that were more in the systems that we recruited from. I'm not sure. And so then we use sequential block randomization, um, just simply by tossing a coin and then alternating the next round of participants so that we made sure we could have equal groups. And out of the 26 intervention families, and I will say for the control group also received the group remote sessions that Amy described earlier. So both groups received that, but the difference is that the control group did not receive the one-on-one peer mentored 10 sessions. So they were able to attend 3 group sessions like once a month. And that's the difference. So across both groups, 55 families completed baseline assessments and 47 completed post assessments. So there were 19 that completed in Texas and 28 in Illinois. Attrition was mainly because of scheduling conflicts, maybe family illness, or we were unable to contact them. So I'm going to share with you some of the results that we had for this. So you can see on the left are the control group results, and on the right are the intervention groups. And this was a measure called improved self-related abilities for health practices. So it's really about self-efficacy and using health practices for the caregiver. So we found that really no differences in these 3 measures for the control group, but we did find slight but significant differences in psychological well-being, exercise, and their total score of this particular measure for the caregivers. And then other outcomes related to the caregivers is that we were looking at physical activity equipment index. So this is measuring, to what extent there's physical activity equipment available in the household or available to the families. And unhealthy food index is more about, to what extent there is, unhealthy food in the household. And so we did find improvement in both of those. So there was more physical activity equipment at the end of the intervention. So I don't know if people were just more conscious about making those materials available. And then there was less unhealthy food available in the household for these families. We also found in the intervention group that there was lower stress, significantly lower stress, between the baseline and the follow-up, and not so much for the control group. And we know that caregivers do experience a lot of stress, so that's super important. And looking at child outcomes, we looked at a number of measures actually. We looked at sleep, we looked at physical activity, food intake, but only one of those was significant for the children. So that was the sleep troubles. So they reduced in the amount of sleep troubles that they had. We're going to be looking more carefully at the other outcomes. We also looked at BMI, but we haven't analyzed that data. But we didn't find the same effect in terms of the sugar intake that we did in the pilot, but we did find a trend in that direction. So it just wasn't significant. So we'll be looking a little bit more about that. We might be able to look at, whether controlling for certain variables would make a difference, like across sites or language or things like that, in whether there would be different outcomes, based on some of those factors. But I will say too that we really feel strongly that strengthening the caregiver, because this is a family household, right? And we're not only talking about the child with developmental disabilities, but also other children in the family, other people in the family. So if the caregiver, who's typically the mother, is the one that's really kind of directing, the physical activity that the family's engaging in, as well as the food and preparing food and all of that, that will eventually lead to better child outcomes. So it may be that we need another follow-up point. Our follow-up measures were done about I think about 3 months after the baseline, after the intervention was over. And so it might be that if we looked at a longer period over time, we might find that strengthening the family caregiver really does impact the child a little bit more. Yeah, so just to summarize, we had caregiver outcomes, which was health-related self-efficacy and healthy food intake and decreased stress, and the children reduced sleep troubles. Um, and then there's the home environment, improving physical activity. And we found high good fidelity across both sites. We were looking at the promotoras and how they were delivering the intervention, and it was pretty consistent. They were meeting all of the um, the points that we wanted them to meet. So in conclusion, we do think that culturally tailored interventions are important and can address health disparities and improve child caregiver and child outcomes. And things that contributed to the success of this program, are things like co-developing the program with Latino families and community stakeholders to ensure relevance, and employing Latina caregivers as promotoras or peer mentors, which improve trust, flexibility, and accessibility, and providing ongoing support to peer mentors to maintain quality and consistency. And that's something I believe Amy mentioned, that we met with the peer mentors regularly to provide that support. And it shows uh, strong knowledge translation, practical implications, and community sustainability in this study. And so we are really interested in seeing if there are organizations that would like to implement this curriculum. We're really happy to share the curriculum with them, with anyone who wants to maybe implement it. It would involve, I mean, we do pay, for this study, we had funding, of course, and we paid the peer mentors for their time. And so if an organization is going to take this on, they would have to do that. But I think it really is a very strong thing to do to have a better impact. So I'm going to stop sharing, and then what we could do is answer questions. Let's see. Yeah, and I think there might be a couple of questions in the Q&A. Okay. We have a question from Carlos, and he says, I'm a lunch trainee from Florida and would like to ask, when would this event's recording be posted so I could review it? Okay, yeah, Carlos,
Can answer that for you, Sandy, actually.
that would be great.
Yeah, so we will be posting these to our YouTube page probably within the next week or so. And I will drop the link in the chat for you.
Okay.
So you can have that.
Yeah, and Carlos is saying he's interested in learning more. And then to the next one, we have Younghwa asks, how did you recruit the promotoras? Which is a really good and important question. We basically tried to identify people who are already emerging as leaders in the community. I'm trying to think Amy, feel free to jump in terms of how we identified these promotoras. I know in the Illinois group, there was a support group that they recruited from. I think we reached out to parent for this study in Texas, and also the Autism Society.
Yes, and then from that we had one very strong parent advocate who was our initial promotora, who had a lot of experience, and then she actually referred couple people in as well. And I think that was the same for for Illinois, that they first recruited from that support group, and then they were referring a couple of people that they know from the community that have been doing some leadership work, and that's how we got connected.
Yeah, great. Does anybody have any other questions about the intervention or any of the research that we presented? Okay. But you can put it in the Q&A, the chat, or just speak, I think, or we can enable you to speak. All right. Well, really appreciate everybody coming. Do you have any other things to say, Hobby, to close?
Yeah, just a quick reminder to please fill out the evaluation at the end of this. And then Carolyn will be reaching out to you for the CEUs. And it looks like we just got a question in the Q&A.
Okay, great. Yeah, so Michelle asks, do you have a higher rate of retention, or did most quit before completing the modules? And yeah, I believe do you remember, Amy, what the retention rate was?
So 26 out of 30 participants in the pilot was completed all 10 sessions, and I believe it was a similar. I have to go back to my slides, but it was a similar rate for our RCT participants. Think, yeah, and then so we do have high retention rate, but what happened with the RCT that was less of an issue in the pilot study was that in the RCT we had more issues with tracking participants in terms of the post-assessment. And whereas the pilot study, we were able to get most of our post-assessments.
Yeah, so in other words, more people completed the intervention, but maybe didn't complete the questionnaires at the end. So then we're not able to include them in the data, but that's about 80%. I'm not doing math in my head right now, but retention
Yes,
rate, which is
it's about 80%. Yes.
yeah, which is pretty good. Any other questions? I mean, I think I would say the challenge might be people initially committing to doing the intervention. So there may be, like, we probably had a lot of interest forms of people, and then after they learn more about it, decided not to do it. But once they're in the study, that's where we have good retention.
Yeah.
Other questions? I'd love to hear from people too about what you think the challenges might be in implementation, because this is an issue that we're grappling with, is how so we developed an intervention, we tested it, it seems like it's very promising, but how do we scale that up? How do we implement it that's outside of a research setting? And I don't know if anybody has any thoughts about that. That would be really interesting to get your feedback on that. I mean, and if you think of something later too, feel free to email us, or you have any further questions, we're happy to answer further questions. But if you have some ideas for us of, like, are there organizations we should reach out to, or, because we're willing to provide, free training and all the materials for free. It's just finding organizations that might implement something like this.
Yes, and all the materials are manualized, so it's
Mhm.
I would think it's easier to implement.
Yeah. I will say, I see that Wei-Wen Zhang is on the participants, and I don't know if he's still on, but he was a former student at UT. He's now an assistant professor, and he wrote a grant proposal to adapt this intervention for Chinese families. So that's going to be interesting. He's just getting started on that project, and something that could be done. It could be culturally adapted for different groups and implemented that way. All right. Well, if we, I think that's all we have, though. Anything else you want to say, Amy?
Just yeah, we are happy to share more information. And yeah, I forgot to mention a point that Sandy did quickly mention about our 3 phases of Poder, and we have papers that's published in all phases. And so if you are interested in learning more about the in what do we do in for understanding this problem and the intervention piece, we have papers that's already been published, quite a number of papers, and so feel free to reach out.
Yeah,
Absolutely.
we have one more question in the Q&A, Sandy.
Okay, thank you. Yes, we've heard of Vela, of course. And in fact, Vela was a partner from the beginning on the UT side. So, you know how Amy talked about we had different advisory committees. The UIC advisory committee, we had a UT advisory committee, and Vela was part of that. And they helped us initially think through some of the elements of the intervention. Yes, they are awesome and they're great to work with. So we're hoping to present our results to, I don't know if any Vela folks are on this meeting, but we definitely want to present it to their team to see, what elements they would like to implement as well. All right, great suggestion though. No, okay. All right, well, I think that's it. We can wrap it up then. And Javi, do you have any final? Probably already did that.
No, we should be good. Thank you guys for joining us.
Yeah, thank you.
Thank you.
Have a great day and a great weekend.